Hello followers of Neurotakeaway, welcome back to the channel. Today we will be talking about neuroimaging in oncologic treatment complications. Just for didactic purposes, I will divide the talk into parts. The first one is the neurosurgical complications, and the second one is the medical treatment complications, especially chemo and radiotherapy. So let's start with the first part today, and I will be giving you the second part next week. Regarding the surgical approach, this is a very important part of the surgery. Nevertheless, it is usually performed by the youngest neurosurgeons. You can see here at the upper row a case in which the surgeons placed a cranioplasty made of bone cement, which is usually very safe, but in this case, it was associated with outward displacement by the brain, which has edema. This is in the jargon called a giant fungus. So this patient had to be reoperated. In the lower case, you can see a metastasis at the level of the right parietal bone with extension both to the epidural and subgaleal spaces. Unfortunately, this child developed necrosis of the skin and of the posterior third part of the bone, secondary probably to a lesion of a branch of the external carotid artery. And this highlights the importance of the plan of the incision before do the surgery, because if the incision is not well done, it may be associated with this kind of lesions. Another complications, in the upper row, you can see a patient that had been operated on for a temporal lobe tumor, and in the post-op, he developed fever and very clearly signs of surgical good infections. And we couldn't perform an MR, but we did this CT with contrast, and you can see the collections both in the deep part and in the superficial part of the cranioplasty, and these collections enhanced very intensely with contrast. So this is a tip, this is a sign that make us suspicious of an MPMA in this particular case. In the lower left case, you can see a complication, fortunately a very rare complication of these cranioplasties made of bone cement, which is the failure of the material. This fragmentation of the plaque into several fragments is very dangerous, maybe made very dangerous, and they had to be removed. And finally, another case in the lower right side, you see a patient that has a craniectomy. You know that the surgeons sometimes, for different causes, they don't place a plastic. In these cases, there is an inversion of the pressures. The atmospheric air pressure is higher than the CSF in these occasions, and there is a sinking skin flap with displacement of the middle line to the other side. This may be associated with headaches and other symptoms. Last month, I had the opportunity to see a patient with movement disorders associated with orthostatic changes in this syndrome. Fortunately, another uncommon complication is those related to the placement of the pins of the frames, especially when the pins are not appropriate to the thickness of the skull of the patient. Sometimes this may produce these collections, epidural collections. In this case, it's very small, very thin, but sometimes I had the opportunity to see huge collections that had to be removed urgently. Regarding the spatulas, this is a case of Pinoblastoma. This is a malignant tumor in the pineal region with restriction on diffusion, and it was approached by a subtentorial approach. This approach is very useful, but it had complication, especially at the level of the Galen vein complex. Sorry. You can see in the lower images the complication, these lesions at the level of the thalami that were produced by spatulas. When the surgery is too long, this compression injury may occur, and it's not, it don't have to be confused with infants. Meningeal changes. Well, after surgery, you usually see this thick dura mater with very smooth gadolinium enhancement. This is called pachymeninges. This is not pachymeningitis. There is no inflammation here. There is engorgement of the veins secondary to intracranial hypotension. And they are usually, it is usually associated with subdural collections, as in this case. In the middle case, you can see this complication, which is called radiculitis. This is due to the presence of hemorrhage in the lumbar sac, especially after posterior fossa surgeries. This produces a plastic phenomenon at the level of the roots, of the coraequinal roots. You can see here the disorganization and the clamping of the roots, including, you can see the enhancement of the dorsal roots at the level of the conus medullaris. And finally, this complication, this is arachnoidal loculations. They are may be very harmful because they compress and distort the spinal cord. And they can be treated with surgery, with disruption of this septile. Another case, this is a posterior fossa medulloblastoma that in the post-op developed paraparesis and urinary retention. You can see the enlargement of the bladder, and there is not much on these T2 sagittal images, but you can see on T1 the presence of collections with hyperintensity in the canal, inside the canal, and on the actual images you can see that these collections are placed at the subdural spaces with this typical Mercedes-Benz sign. These collections are usually asymptomatic and reversible, spontaneously reversible, but sometimes, as in this case, they can be associated with symptoms. Regarding Csf Fistulas, they are very common. You can see in the upper case ventricularization with the passage of CSF from the ventricles to the subarachnoid space, and from there to the subgaleal space, producing this pseudotumor. This can be treated conservatively with compression, with postural changes, but sometimes they deserve the placement of a catheter. In the lower case, you can see a typical pseudomeningocele after a posterior fossa surgery. This is very common in adults, especially in adults, because in adults they usually don't place cranioplasty early after surgery. This is another case of Csf Fistula. This was a teratoma of the cerebropontine angle. This was approached via temporal retrosigmoid approach, but unfortunately there was a lesion of the petrous bone with CSF fistula from the middle fossa to the middle ear that had to be treated with the placement of aponeurosis at that level. Moving on to another step of the surgery, which is the middle of the surgery, the removal of the lesion. This is usually associated with very peripheral injury. And this can be seen very nicely in the post-op, in the immediate post-op, as in this case, by the sequence of diffusion, because these lesions are associated with restriction. And it is very useful to see that, because in the subacute stage, these lesions may enhance, and this enhancement may be confused with residual or recurrent tumors. After a while, this enhancement of this scar disappears. You know that we try to study the patients very, very soon after surgery. In general, it is said that in the first 48 hours, that's the right time to study our patients, because in that period there is no scar enhancement. But on 3T, maybe that's not true. Maybe you can find early enhancement, and in those cases you have to trust on the shape and the place of the enhancement. Sometimes these scars may enhance for a long time. This is a case of a patient with a right parietal tumor that had been removed 1 year earlier. You can see the persistence of this enhancement, but you can see that this is a thick linear area of enhancement associated with retraction of both the ventricle and the subarachnoid spaces. So this is very straightforward for a scar. Other complications that are very common are the presence of intraventricular hemorrhage and pneumoventricle. Regarding pneumoventricles, they are located at the frontal tips of the ventricles or at the level of the frontal subarachnoid spaces. They are usually asymptomatic and they reverse after 1 week. On the other hand, the presence of blood is located at the occipital horns of the ventricles, and they can be very nicely seen on CT. But the problem is when we have to diagnose an MR, because on MR, these collections of blood may have restriction, and this restriction may be confused with pus. So the solution of this is to see other sequences as SWI, T1, to realize that this content is blood and not pus. You know that in recent years there is a trend to more and more or less and less aggressive surgeries. And the case of craniopharyngioma is a very nice example of this. Now, when we find a large tumor that compresses or infiltrates the hypothalamus and has a single cyst, it is a typical ideal case for the placement of a pneumatic catheter through which we can administer interferon, which is a useful drug for this tumor. But in some cases, as in this one, the wall of the cyst has calcifications, and so when the catheter traverses this wall, produces hemorrhage around the wall and in the subarachnoid spaces. We have to be ready for these complications in these cases. Regarding other cases of perioperative injury, there are some typical syndromes associated with certain surgeries. For example, in this posterior fossa tumor, there was a pilocytic astrocytoma There is no restriction, a very typical peripheral enhancement. And you can see in the post-op the lesion of the paravermial areas and the dentate nuclei, which is associated with this syndrome of mutism. This mutism may persist for a while, weeks, months, but it is usually reversible. And it highlights the importance of the cerebellum in neurocognitive and behavioral functions. Let's go to this case. This was a sad case because this was, again, a medulloblastoma. In this case, group 3 medullo with enhancement, restriction, a midline location. But in the post-op, the patient developed an infarct with infarction and hemorrhage at the lower part of the cerebellum with compression of the brainstem, and the patient did badly. Regarding infections, fortunately, nowadays they are less common than a few years ago, but we still see these cases of abscesses after surgery. The problem with these abscesses is that sometimes they are hard to detect on MR because, again, blood may be confused with pus. They both restrict at the subacute stages. So in this case, there is no problem because you can see this round lesion with a typical enhancement of the wall with restriction in the inner part, with other areas of restrictions. There is no hyperintense on T1, so we are very straightforward that this is an abscess. But there are other areas here. You can see enhancement at this level without restriction. This is probably scar and or tumor. So we have to be very careful with this diagnosis. Another complication related to infection is the presence of meningitis. In general, meningitis is diagnosed by clinical findings and by CSF studies, but sometimes we can see certain complications, as in this patient that had a medulloblastoma, in this case a group 4. It was removed, and after that they detected meningitis, and after a while the patient did badly, and you can see here on diffusion the presence of huge infarcts supratensorally in both brain cerebral hemispheres, both superficial and deep areas, and also the watershed areas. And this was associated with vasculitis and or spasms of the internal carotid arteries at the level of the cavernous sinuses. And finally, I would like to stress the importance to understand that the cavities that are left by the neurosurgeons after removing a tumor may change over time. And this is normal. You can see here a patient studied 3 months after the surgery. There is a cavity with hyperintensity in its interior that probably is related to liquid with a high protein content, and it has mass effect on the surrounding parenchyma, where you can see remaining tumor. But 6 months later, you can see that the cavity is smaller and there is less mass effect on the surrounding parenchyma. So you may think that this tumor is better, but in reality, there is no change. There is no important change in the amount of tumor. There has been a change in the cavity, which is not that important. So to finish up, I would like to remind you that neurosurgery had evolved a lot during the last years, during the last decades, and during the last centuries. Now there is a very close relationship between neurosurgeons and radiologists in order to treat better our patients. And I have the pleasure to work with very good neurosurgeons. I would like to recall this saying by a crack of neurosurgery, as was Wilder Penfield. He said that the brain is the organ of destiny, and it holds within its humming mechanism secrets that will determine the future of the human race. See you next week. Bye-bye.